Yeah, good evening, everybody. I am Dr. Vivek Nangia, Chief of Pulmonology for Cluster 1 Max Healthcare and Vice Chairman and Head for the Max Institute of Respiratory Critical Care and Sleep Medicine at the Saket Complex, Delhi. And it's indeed my proud privilege, honor, pleasant duty to welcome you all this evening to this very important webinar on parasomnias. We as pulmonologists tend to focus only on sleep apnea and don't go beyond that. Whenever there's a situation beyond that, we tend to refer our patients to a neurologist probably or a sleep technologist. But unfortunately, there are things that get missed sometimes even by them. And this evening, what we're discussing is about parasomnias. Parasomnias again are more common than we actually think they are because patients don't even reach the doctors sometimes. Parasomnias are all about the abnormal movements, behavioral disorders, emotions, perceptions, dreams. And I'm sure you would have seen parasomnias being enacted in various movies, whether they're in Bollywood movies or Hollywood movies. But are they for real? Is there a treatment? Is there a way of diagnosing them? And what harms can they do? There's a lot that we can talk about this evening. And all that is lined up for you today by a galaxy of stars that we've collected. But before I go on to that, I'd like to thank ICS for giving us this opportunity. First of all, for choosing such a brilliant topic, very interesting an exciting topic, and giving us this opportunity to discuss and interact with you all. We are very happy to announce that we have almost 1,880 registrations for this evening, out of which more than 1,700 have logged in already. I think it's just a matter of time when we cross this figure as well very soon. So I'd like to thank Dr. Samaria, the president of ICS, Dr. Rajadhar, secretary ICS, Dr. Amita Nene, the lady behind the entire academic march of not just the ICS but the IB and so many other organizations. I think she's just taken it to herself as her onus that she'll probably touch every student in one way or the other and educate all pulmonologists in one way or the other. I'd also like to thank CIPLA for their unflinching support and always being there for us, and especially Hiten, who's made a lot of effort in making this webinar a huge success. So, without wasting much time now, I'd like to hand it over to Dr. Uma Devraj, who's going to tell you about all that you should be knowing about parasomnias. And the first talk will be followed by a panel discussion. As I said, we have a panel, galaxy of panelists with us. I'll introduce the panelists later, but let's start with Dr. Uma Devraj's talk. Dr. Uma Devraj is a very famous, very popular, very renowned pulmonologist of the country, based out of Bangalore, a very prestigious hospital, the St. John's National Academy of Health Sciences. It's really an honor and privilege for us to have her this evening with us. She's professor and HOD of the Department of Pulmonary Medicine there and has conducted many national conferences, international workshops, sleep workshops, has almost more than 50 publications to her credit. So it's really actually a privilege for us to have her with us this evening for this webinar and to talk about a topic like parasomnia, all you need to know. So, Dr. Uma Devraj, over to you.
Thank you. Thank you for this opportunity. I should thank Dr. Amita and the ICS and the Supla team for giving me this opportunity. Let me start by sharing my screen. Is it visible?
Yes.
Okay, yeah. So let me straight go to the topic of today, parasomnias. Now, as pulmonologists, all of us are, I think, very well versed with obstructive sleep apnea and the treatment and approach to it. Parasomnias are also quite interesting, but many of us need not back out from, approaching the cases who present with parasomnia or how to approach and how to diagnose and treat them. So, what are parasomnias? Parasomnias are defined as an undesirable physical event or a sensory experience that can occur either when a person is entering into sleep, during the sleep, or when they are waking up or arousing from sleep. And many a times it is because I'll tell you about the pathophysiology, it is the interlude or the intermingling of arousal state with the sleep state. So there are few disorders of arousals like sleepwalking and night terrors, and sleep wake transition disorders like bruxism or rhythmic movement disorders. Sometimes when people are just, especially children, when they are just going into sleep, they're falling asleep, they exhibit some rhythmic movement like head banging, and then they drop off to sleep. So that is also a sleep disorder. That's also a parasomnia. And very widely known, or sometimes it is pathological also, REM parasomnias, which are exhibited as sleep behavior disorders, are quite interesting. Now, why should we bother about diagnosing or approaching a parasomnia? Because many a times these nocturnal events can mimic epileptic seizures, sometimes even psychiatric events. And so it's very important to have a very clear description from the observer. Many a times it's the bed partner or the parents or people who have closely observed what is happening to the person at night, and this helps majorly in diagnosing the parasomnia. So, as I said, parasomnias are a state dissociation disorders. So, here we see that. So, here parasomnias are overlapping states, in the sense like we have a wake state, we have the REM sleep and the non-REM sleep. So whenever we have intrusion of wake state into either the REM or non-REM, this results in parasomnia. So when you have a wake state which is intruding, or there is incomplete transition or oscillation from one sleep state to the other, then this results in disorders of arousal or non-REM parasomnias. And whenever we have a wake state intruding into the REM, then we have the REM parasomnias. So, how do the movements manifest? What is the deciding factor which results in this particular parasomnia manifesting? Say, some people might have sleepwalking, some parasomnias present as sleep talking, somebody can have an eating disorder. It all depends on which type of the central pattern generator. So you can see in this figure, there are lot of central CPGs, what we call central pattern
One
generator.
minute. I think we can't see your slides. Is everybody able to see the slides? I'm not.
Oh, okay.
Yeah,
No,
I can
I can see it's
yeah,
clear.
we can see
I
the
can see.
slides.
Yeah.
What is
Oh,
wrong? I can't see the slides. I can only see her.
oh.
Acha, okay, chalo. If everybody is able to see, then it's okay.
The technical team should be able to address that. Is it okay?
Yeah,
No,
slides are
even in the
visible.
audience link, the slide is visible. have logged in by audience link also in another
Fine,
room. Even that slide is visible. Please continue.
fine. So these are the central pattern generators. These are particular neurons which are situated both deep within the brain, in the brainstem, as well as in the spinal cord. So these are responsible for very complex movements, like, for example, breathing, chewing, or sometimes protective reflexes like swallowing. So these are typically aroused when you are awake, and then it is very active. And many a times, this breathing and all is also active during sleep. But whenever there is a mixture of states like arousal and sleep, so partial arousal state might activate the discrete central pattern generators, and this results in the person, though he or she is sleeping, if that particular central pattern generator is activated, this results in the movement or particular arousal and behaviors. Like, for example, if the CPG responsible for the alimentary system is aroused, then bruxism or oral automatism results. Or if the locomotive CPG is activated, then the person exhibits sleepwalking or cycling. Some many a times it can be parasomnia, but if it is a very stereotypic behavior and it comes repetitively in the night, that is called as epilepsy. So we have to differentiate these two also. Parasomnia from epilepsy also depends on the timing of the event, how frequently it is occurred. So we'll come to that in the later slides. So, how are parasomnias classified? We have the non-REM sleep related parasomnias, which are disorders of arousal. Sometimes, though the semiology is different, for example, confusional arousal, sleepwalking, sleep terror, most of them have a very similar pathophysiology. It just depends on how the parasomnia is manifest that they are named as such. For example, in confusional arousals, person is in very deep sleep and arouses suddenly. Of course, they are not having any autonomic manifestations. They are just awake. Their eyes might be open. They are confused. But if you ask them actually in the morning after they wake up, they might not remember it. So, similarly, sleepwalking. Sleep terrors is slightly different where the person is in deep sleep but suddenly awakens with a sudden shrill or a cry, and then they have excessive autonomic dysfunction in the sense they have sweating, they have tachycardia. So, this is a type of manifestation. Related eating disorder is also very unique in the sense patient actually is in deep sleep but they manifest as going and eating many a times high calorie food, sometimes even non nutritious food also. We have people reporting to eat soap, liquid soap, or sometimes cat food, things like that. So these are non REM related sleep parasomnias. Then we have the REM related parasomnias. Very typical is REM sleep behavior disorder. And then we have a recurrent isolated sleep paralysis, which is very prominent feature in narcolepsy, but it can occur isolated without narcolepsy being manifest. And then we have the very well known nightmare disorder. And then there are certain other parasomnias which are neither here or there, but yes, it can happen. Exploding most often in non-REM actually. Exploding head syndrome, sleep related hallucinations, sleep enuresis, very common problem in children especially. And then you have parasomnia due to a medical disorder or a substance, and sometimes it can be unspecified. So now let us go deep into non-REM parasomnias. So these are disorders of arousals. We have confusional arousals. I have given a brief introduction about these confusional arousals, sleep terrors, sleepwalking, and sleep-related eating disorder. So here, what happens is person is actually in deep sleep. Usually occurs in the first half of the night. Usually occurs in N3 stage of sleep, and they manifest in a confused demeanor, and sometimes the eyes are open and it looks as though that they are staring. And during an episode's eyes are often wide, they have a glassy stare, and if you try to wake them up, they are completely confused. They'll not be able to be arousable. So, what is the criteria for diagnosing these disorders of arousal? So, sometimes they might have repeated episodes in the same night, but it is usually rare. Most often, it is usually one episode only. So here they have partial or incomplete awakening from non-REM sleep. And patients respond inappropriately, and sometimes, many times, they might not respond to any efforts of the witness or observers to intervene or read. Sometimes it is noticed that patients are sleepwalking and they might end up injuring themselves. For example, person might be walking and they might jump out of a window. So we will see how to prevent self harm and injury to the others also. So during that episode, it might be very difficult to awaken them. And when they wake up, there might be little or absolutely no memory of what has happened during the night. So absent cognition or dream imagery after the event, and no recollection after the episode, and absence of any other primary sleep disorder is a must, either a mental disorder, medical condition. So none of this must be present to diagnose this particular disorder of arousal. So here you can see a confusional arousal sleep polysomnogram. This is a 90-second 3-minute polysomnogram. You can see that patient is manifesting what is called as a cyclical alternating pattern, CAP. So here you have interludes of sudden bursts of activity followed in a background of EEG activity, and one particular sudden burst is followed by this person exhibiting arousal and even sometimes attempting to climb out of bed. So this is very common. So increased cyclical alternating pattern, which suggests that the non-REM sleep is in not very stable. So they might switch between awake and arousal. So this is a common pattern seen. So another parasomnia like sleep talking, many of us would have noticed that children, especially exhibit this sleep talking. So almost 50% of the young children have these episodes sometime or the other. And if you see overall, all the population, lifetime prevalence is estimated to be approximately around 65%. But as the children age, during adolescence and early adulthood, the sleep talking reduces. And in adults, if you take, it is only around 5% of prevalence, the sleep talking is seen. So the frequency and timing of events is very important. Usually, it is usually occurring only a few times per month or in weeks. And rarely, as I said, it is usually only once per night. Very, very rarely, it can be more than once in a night, and usually occur in the first of the night. So we know that the first half of the night you have the cycles of patient going from N1 to N2 to N3. So N3 has a longer duration during the first half of the night. And as the sleep progresses, you will have further cycles where the REM appears, and usually during early morning, the REM duration also increases. So the N3 occurs more in the first half of the night. And so these parasomnias, which are non-REM parasomnias, are more predominantly occurring during the first half of the night. And the duration of the events are usually from 20 seconds to few minutes, and usually they are in very deep sleep, and sometimes these terminate either in wakefulness or they switch over into a lighter non-REM sleep. So there are few precipitating or predisposing conditions for these parasomnias. We can see that sometimes if the family other family members have a family history of disorders of arousal, then these index cases can also manifest such. Few genetic abnormalities are also known, but they are not very widely studied or confirmed yet. Certain conditions can predispose. For example, if we have a very disruptive sleep environment, it is all very loud, or a lot of lighting is there in the place where the person sleeps, or there are loud sudden wakening noises, then this can precipitate an event to occur. Disruption can be due to other primary sleep disorders. For example, here what is shown here, sleep fragmentation, and what is shown in this blue box here, sleep fragmentation, is a person with a sleep apnea. You can see all the blue bars there. These are particular sleep apneas, and we can see that the dip in the red line is hypoxic events. So whenever these events are occur, there is sleep fragmentation, and this can cause a cortical arousal and result in a disorder of arousal. Other sleep disorder conditions like narcolepsy, restless leg syndromes, these also can lead to a transient, transition, incomplete transition into a wake state, or a intrusion of arousal into the sleep, and can cause this disorder of arousal. Sometimes even a full bladder, fever, or emotional stress can also result or precipitate a parasomnia, resulting in the patients exhibiting these behaviors. So what typically happens during a confusional arousal? So person is in slow wave sleep, that is in deep sleep. There is a sudden arousal either precipitated by a, say, emotional distress, or patient has been sleep deprived. I had a patient who was preparing for exams for almost many weeks, so couldn't sleep properly, and then his roommate was reporting that suddenly he had this confusional arousals, and then sometimes sleepwalking. So this is a very typical non-REM parasomnia. So they'll have sudden arousals, confusion, which can be manifested either as a mumbled speech, they might be disoriented. So if it is only sudden arousal, they might not move from the bed, they might just be waking up. They can have some few hand movements, just vaguely searching something in the air, something like that, but usually it doesn't result in walking as such. But some of the arousal, sleepwalking especially, patient can get up from the bed. They might have wide open eyes, but it will be almost like they are not in that particular place. They have a very blank stare. They can walk around, they can hit themselves in furniture, or use certain objects also. So that is sleepwalking. Sometimes they might exhibit inappropriate behavior. There is a particular type of confusional arousal, what is called as sexomnia, where person might exhibit inappropriate behavior or indulge in sex with a bed partner, but they might not have any memory of what has happened during the night. So this results in amnesia for the event. And then once the event is over, they rapidly return to the baseline and resumption of sleep occurs. They might even go to slave wave sleep again. So this can be cyclical. So this is a particular sleep study of a person with a confusional arousal. Here you can see person is having a deep sleep, N3 sleep. You can see a lot of delta waves in the upper two channels are I channels, and the four which are just below the upper two channels are the EEG channels. You can see nice delta waves, and suddenly there is a sudden outburst of EEG activity, and person is getting up. There is verbal confusion and there is a puzzle behavior. So this is what is typically seen in a confusional arousal. So here you can see arousal followed by confusion. Patient is walking around. She's also, moving around with a pillow. So, but the glassy stare is there. She doesn't know what she's doing. So these movements can range from simple automatic, not goal oriented behavior. Sometimes it can be even violent and inappropriate or agitated behavior also. So, as I said, precipitating factors like use of sedatives, though the treatment for these sleep behavior disorders are sedatives, sometimes use of sedatives can precipitate these parasomnias. Acute sleep deprivation, as I said before, the person who was preparing for exams had a precipitated attack. So, not only that, any, say for example, person is working heavily and needs a deadline to be met and they are sleep deprived, can have precipitation of these parasomnias. And any specific cause of arousal, for example a sudden noise, it can worsen or precipitate the occurrence of parasomnia. Other conditions like fever, untreated sleep apnea, stress, or even a distended bladder can precipitate. So, sleep terror or confusional arousals. So, these other like sleepwalking or confusional arousals are more gradual, like in the sense when you actually observe the person or the witness who is reporting these behaviors, they say that person behaved normally as though nothing is happening. They just have this glassy stare, they are walking around, they are not agitated or, disturbed in any other way. Sometimes, but sleep terror, if you see, it is sudden in onset, but person will awaken with a terrible scream. They are completely afraid or they are mortally afraid, and they have lot of other autonomic manifestations, like they can have tachycardia, tachypnea, and they are completely not able to be awoken at all. So, in fact, when a person tries to awaken them, it can worsen the attack. So that is the event. And as mentioned previously, prevalence is seen in 4% in adults, whereas it is more common in children. So here is a typical example of a sleep terror. You can see this, the other sibling, fell off the bed. Okay, so that created a noise, and then that resulted in this little boy having a sudden episode of a sleep terror. So, the attempts to interrupt the behavior can deepen the confusion and it can cause even aggression. So, we have to be very careful about it. So, but what differentiates sleep terror from nightmare? So, many times it is important at what time this disorder occurs. So, sleep terror is usually seen in the non-REM period, so N3 sleep. So, usually more common in the first third, whereas a nightmare is more common in the last third or during REM. And EEG characteristics, if we say the sleep terror is N3 sleep and nightmare is usually a vivid dream and all is more common in REM sleep. So, movements are more common in sleep terror, whereas when a person is experiencing a nightmare, usually it is only a dream state. They might not exhibit any movement as such. And there is severe anxiety when a person is having a sleep terror, but especially in children, the parents are very scared. What is happening to the child? Why are they screaming? They're not able to grasp because the environment might be stress free, but the child is screaming. So they might be very anxious about it. Not only the person who's undergoing the parasomnia, but the bystanders also. The severity of the event can be quite severe sleep terror. It might be very scary to look at a person who's having such an attack. Nightmare, usually nothing happened. The person is completely asleep. When they are waking up, then they recall that they had a terrible nightmare, and they are just they'll be able to vividly recollect what is happening during the sleep. So many a times injuries, violence, or displacement from the bed is more common in sleep terror, but it is very, very rare in nightmare. Usually person is completely asleep, and then only when they wake up they are able to recall the event of the nightmare, whereas there is no recollection for sleep terrors. So, what are the other non-REM sleep, like sleep eating behavior? As I said before, they can eat very high calorie diet. Sometimes, because at night they are eating, they can visit the fridge and whatever is available, like sweets or cakes, and then in the morning they feel that their stomach is upset and they are having distension. They might have aversion to food in the morning. So it can result even in that. Sometimes they can even end up eating non-edible substances, like for example cleaners, floor cleaners, or cat food, and sometimes sandwich with a frozen pizza and some sort of an oil. So sometimes it can be quite dangerous in a person who's having a sleep eating disorder. And sexsomnia is a type of a confusional arousal state. They can have inappropriate behavior, sometimes like masturbation or attempting sexual behavior with a bed partner. Especially, it can be problematic, which can have legal implications. For example, it happens in a place outside their home situation. Then it can result in litigation, and also they have to be very careful about this. So, how do we evaluate these conditions? Most important is the history, either from the patient. Most often, patients are not able to remember what has happened to them, but a keen observer, a very vivid and well documented. Sometimes, many times we see patients or the parents video recording what is happening, because now everybody has cell phone, so they record and then show us what is happening to the patient. So this is very, very important to diagnose what is the type of parasomnia. And many a times, but we can only confirm when we have searched and ruled out other sleep problems. So search for other associated features. What are the priming factors? So what are the sleep related events? Whether person has associated sleep apnea, what are the limb movements? Many a times RLS or periodic limb movements, can those movements can precipitate a parasomnia. Sometimes you have to take a detailed medication history, because these can provoke the parasomnias. And as I said previously, it is all semiology, in the sense all non-REM parasomnias are falling into the same group. It only depends on how they manifest. So confusional arousal is just an arousal with mumbled speech, or just sitting up in bed and looking around in a dazed state. And if that results in walking, then it is termed as sleepwalking. And that walking results in a sleep eating behavior, then we call it as sleep eating disorder. So it is mostly one similarly occurring type of parasomnias. So we have to note the age at onset, most common in children, and as they age, the frequency comes down. Sometimes it disappears altogether. What is the severity of the parasomnia? What is the complexity? Is it just a few mumbled words, or is it more complex movement and interaction with the surroundings? Sometimes they might interact even with inanimate objects, and then or eating behaviors. What is the duration? Usually lasts from few seconds to few minutes. And many times we can have even video evidence, but most of the time, the bystander also, they might be sleeping. The observer might be sleeping, so the start of the events might be missed. For example, the start of the event for sleep terror is very important, because usually the sleep terror, they start with a piercing cry and they scream aloud, and then all these autonomic manifestations are there. If we don't have that start of the event, we might end up not able to diagnose the condition as such. And general physical examination is very important, detailed neurological examination, because these can give a clue for presence of any other neurological disorder or other problems in these patients. The differential diagnosis for non-REM parasomnia is very important to rule out frontal lobe or inferomedial temporal origin nocturnal seizures. So these, how do we differentiate? Even from history also we can differentiate, but it is better that you even demonstrate them by a polysomnogram. Many times these seizures will have stereotypical behavior, in the sense every event which they have, they'll have a similar type of action. Like for example, a person has just folding of the hand, or squeezing of the hands. That might be a every event. Or say for example, in a month they have 4 events, all the 4 events will have a similar type of behavior. Not so in a parasomnia. In a parasomnia, every event will be different. They might manifest in, say, in one they might be moving in one direction, in another they might be walking or sitting in some place. So every event might be different. If you see a stereotypical behavior, then it is suggestive of more of a frontal lobe seizure. Another differential diagnosis is Klein-Levin syndrome. Of course, this has lot of other features, like they can exhibit hypersomnia. They also exhibit hyperphagia and hypersexuality. But with the presence of these other sleep history, we will be able to differentiate them from parasomnias. So another important thing is to look for associated other sleep disorders. For example, patients with confusional arousals, 13.2% of them had associated OSA, whereas if you see people without confusional arousals, only 2% had obstructive sleep apnea. So we need to look for other sleep disorders. Now, how do we treat? Now, safety interventions are more important. So these parasomnias many a times just need reassurance. Many times it is only concerned parents. They are very worried about what is happening to the child. So we should ensure safety, that they do not hurt themselves or the others. So protect the patients, remove sharp objects from the bedroom, cover the windows so that they don't, move out through the doors, or ensure, that the doors are securely locked. Place door alarms, remove all any sharp furniture or objects. Avoid the precipitating factors, like you have to have a very protective sleep environment. Improve the sleep hygiene. The sleeping area should be dark. They should not have very loud or startling noises. Sometimes hypnosis, or we can instruct the parents that if if the parasomnia is occurring at a particular time of the night, 15 to 20 minutes before that night time of the occurrence, they'll be able to gently awaken the child, make sure that the child responds by verbalizing, and then allowing the child to go back to sleep. So many times this can help in avoiding the occurrence of the parasomnia. So if all this is not helpful, then there is pharmacotherapy. If the episodes are very frequent, they are very severe or disruptive, and can result in injury to the patient or the others. So then we can suggest some pharmacotherapy. So here is a complete gist of what type of treatment. So we can, most important is environment safety across all the parasomnias. Reassurance is very important. Sometimes even cognitive behavioral therapy to the patient, and you can ensure, you reassure the parents and tell what is the actual cause. Mindful uh, meditation, MBSR. And you also end up, if they have associated sleep problems or medical conditions, to treat them. Many times this is more than enough to prevent them from having further episodes. So scheduled anticipatory awakening is also quite important in confusional arousals or somnambulism. So this can help in preventing the occurrence of the event as such. So across all these parasomnias, non-REM parasomnias, if the events are very severe and if it is quite injurious or it is hampering their daytime functioning, we can offer pharmacotherapy like clonazepam. So that helps to, it is the pathophysiology is intrusion of arousal into the sleep state. So you try to put them into a deeper sleep by giving them sleeping agents like clonazepam. Even melatonin is also preferred, but these can also help in patients who are having some neurodevelopmental problems, for example, in autism. So, melatonin is also helpful. So, other behavioral managements like we have to reassure the patients, avoid the precipitants. So, they are very important. Specific pharmacological management, for example, in confusional arousals, we can offer clonazepam, and in sex omnias, again, clonazepam is a drug of choice. Other choices are antidepressants and anti-epileptics. For sleepwalking, again, try to put them to a deeper sleep by giving clonazepam, benzodiazepines, or antidepressants. So, across the parasomnias, many of these agents are quite helpful. Now, coming to REM parasomnias. So, though non-REM parasomnias are innocuous and most of the time they don't need treatment, REM parasomnias are different. REM state is a very complex sleep state in the sense it is a active brain in a paralyzed body. So the if you see, it is very well characterized by muscle atonia. During REM sleep, person is not able to move their limbs. So, whenever there is a loss of REM sleep atonia, this can result in a dream enactment behavior. So, all of us know REM sleep is the time where person has lot of dreams. Of course, there are dreams in non-REM also, but they are not very vivid or so very colorful as that seen in REM sleep. So, whenever this REM sleep dream is not associated with the atonia, then they end up enacting the dream and that can result in lot of problems. So the prevalence is around 0.34 to 2% in the general population, and majority of these REM parasomnias are seen in males, almost 80%. So it's usually seen in older adults. So the mean age at diagnosis is around 52 to 68 years, and most of it REM parasomnia can be a precursor to synucleinopathies, which include Lewy body disease. For example, a person who is diagnosed with a REM sleep disorder, like parasomnia, after 4 or 5 years, they usually develop or phenotypically they change into Parkinsonism. So they can manifest as Parkinson's disease, dementia with Lewy bodies, sometimes pure autonomic failure, or they can also be associated with multisystem atrophy. So this is a concerning parasomnia. REM parasomnia can later on develop into Parkinson's or other Lewy body associated synucleinopathies, what is known. So the prevalence of RBD in Parkinson's disease is somewhere around 15 to 65%, and it is almost 68% in dementia with Lewy body disease. Sometimes it can be very rarely seen in other neurodegenerative disorders. And most important thing to note in REM parasomnias is it can result in serious injuries both to patients and their bed partners, sometimes even as severe as resulting in fractures, subdural hematomas. Because what happens most of the time, dreams are such that they are trying to protect themselves, like they are fighting with somebody or they are fighting some animal. So they have pugilistic manner, they'll be boxing, they'll be kicking, and so this can result in self injury or injury to the bed partner. So the motor control is lost in the REM sleep. So this also can be seen in certain other sleep disorders like narcolepsy. Particularly REM sleep disorder is seen in almost 30% of patients with narcolepsy, and it can be also a rare paraneoplastic and autoimmune encephalopathy manifestation. So many other very very rare neurological disorders can also be manifested as REM parasomnias. Rarely, antidepressants can cause RBD idiosyncratically. Sometimes RBD might be pre-existing, and when these patients are put on antidepressant, it can unmask the presence or manifestation of the REM behavior disorder in these patients who have otherwise a subclinical synucleinopathy. So it in fact can precipitate or unmask what is pre-existing previously. So what happens in REM parasomnia? The pathophysiology is there is a REM sleep generator, which is the REM sleep usually is starting from the ventral and rostral area, which is in the local ceruleus, that is in the midbrain. So there you have glutaminergic neurons in the vicinity of these neurons. So glutamin is actually an inhibitory neurotransmitter. So these inhibitory neurotransmitters are responsible for regulation of REM metonia. So they will go and inhibit all their anterior and ventral spinal motor neurons. So whenever there is loss of these glutaminergic neurons or the neurotransmitter is reduced, so the REM sleep generator is not inhibiting the motor areas in the spinal cord or the CPGs. Then this leads to the RBD. So interruption of these pathways, either in the pontine, medullary, or spinal cord, results in lot of these manifestations. So here you can see in this video, this person also has an associated obstructive sleep apnea. So you can see he's using the CPAP. So you can see how he's kicking the bed sheets. He's trying to escape some danger which is occurring to him. So that is a very typical REM behavior disorder. So what is the diagnostic criteria? This is the presence of REM sleep without sleep atonia, muscle atonia, which has to be manifested in the polysomnogram. Sometimes sleep related injuries. Suppose we are not able to demonstrate by polysomnogram because not every night the disorder can be manifest. So actually when you're doing a polysomnogram, the episode might not occur, so we might not be able to identify that. But if you have a very strong history and the bed partner is able to describe, or sometimes it is that the bed partner is reporting to the medical person with injuries and say a black eye or something like that, and that the bed partner, the person's RBD has resulted in such injuries, we can label this as a probable RBD. So this can be related to and or abnormal REM behaviors during the polysomnogram. And during the polysomnogram, we should demonstrate absence of epileptiform activity. And there should be no better alternative explanation for the sleep disturbance. So these are the criteria to diagnose REM behavior disorder, RBD. There are few questionnaires also, but their questionnaires are not very sensitive or confirmatory of RBD, a strong history. And if you are able to demonstrate during a sleep study, that is the gold standard. But questionnaires can help. A single question like, is there dream enactment? That itself has shown almost 90% sensitivity. There is a few item related, like 10 questions in Mayo Sleep Questionnaire, REM behavior, sleep disorder screening questionnaire. But as I said, rather than the questionnaires, it is better to have a good history and demonstrating the behavior in a polysomnogram. So here,
Uma, sorry to interrupt, but can we wind up quickly now because we're running short of time?
Okay. Okay, fine. I have, I think, another 5-6 slides.
Can we just hurry them through really?
Yes. So this is the REM sleep behavior. You can see the normal REM, we have absolutely no chin EMG activity. During the REM sleep, you should have chin EMG activity. There are certain other features in REM sleep behavior disorders. Again, the treatment is again to reduce the dream enactment behavior. But again, safety of the patient and all the other safety measures has to be ensured. Sometimes treatment with uh, clonazepam or melatonin is also helpful. Certain other parasomnias like exploding head syndrome, where the person suddenly arouses with a sensation that something has exploded inside the head, but this is usually painless. And sleep enuresis is very common in children. More than usually by the end of 5 years, most of the children do not wet their bed. But if it is going beyond that age, then this is also a parasomnia. But as they age, this disappears. Okay, a particular thing called as sleep paralysis. It's very well known in narcolepsy, but it can manifest isolated without narcolepsy also, where the person awakes. they are completely conscious, but they are not able to move at all. So this is the intrusion of REM atonia into awakening state. So again, this we have to differentiate sleep terrors from nightmares. This I've already explained in detail. How do we approach parasomnias? So most important is the patient at risk for potential harm or causing harm to others. What are the driving incidences or appear things which are leading to these events? And do these events indicate other underlying disorder? So most important is the history, what are the precipitating factors, and there are some clues to REM sleep behavior disorders like other neurological. So a detailed neurological examination has to be done. For example, sometimes Parkinson's disease, they can have decreased sense of smell, constipation, or some autonomic issues. So that will give us a clue whether these patients have REM behavior disorder. So when do we, most of these parasomnias do not need a polysomnograph to confirm the diagnosis, but we do end up doing a sleep study. For example, if there are atypical presentations, if the events are injurious to the patient or the bystanders, if it is significantly disturbing the patient's home life, it is an unusual age of the onset, or sometimes stereotypical events, you want to differentiate that from epilepsy and parasomnias. So this is the summary slide. So how do we differentiate? Depends on the time of occurrence, whether it's in the first half of the night or later half. Is it a stereotypical behavior, or is it like a complex disorder, complex movement like walking and talking, and whether the person is able to remember the episode or not? What is the autonomic manifestation? Sometimes in sleep terrors, they'll have tachycardia and sweating. And how many minutes does it last? Usually very, very brief episodes. And most often when they are awakening in the morning, usually the parasomnias, they will not be able to remember the episodes. So that brings us to the end. Thank you so much.
Right. Thank you, Dr. Uma, for a very insightful talk and very, very engaging. I think this is the best talk ever I've heard on parasomnias, truly. It was extremely informative, made a very complex topic seem really very simple. So I think we'll straight away go into the panel discussion now. And let me introduce the galaxy of stars that we've collected this evening for all of you, starting with somebody who's very well known, renowned in the field of pulmonology, who recently conducted the NAPCON and will be conducting the BronchoCon next year. None other than our dear friend, Dr. Nitin Abhyankar, who has more than 100 presentations to his credit, more than 25 publications to his credit. I mean, he's not just a good pulmonologist, but is also a good poet, writes a lot, and I think has his own YouTube channel as well, if I'm not mistaken. So, very, very talented. So, it's really an honor and privilege for us to have you with us, Nitin, this evening. Next, we have Dr. Supraja. Dr. Supraja is all the way from Chennai. She's joined us this evening. She's a lead consultant director at Medway Institute of Pulmonology, involved in pulmonary rehab, and has a lot of research work to her credit, including genetics, developing of lung organoids for future lung transplantation, and 3D printing of lung model, as well as has been researching into WAP in cardiac surgical patients. So, welcome, Dr. Supraja, to this platform. And I'm happy to say that we have the stars from across the country today: Pune, Chennai, Bangalore, Dr. Uma Devraj, and next comes Dr. Kapil Iyer from Mumbai again. So, Dr. Kapil Iyer is trained exclusively in lung transplantation. For him, uh, parasomnias is not something very difficult to manage really. So, it's a routine for him to be handling these kind of patients as well, despite specializing in lung transplant. He has more than 200 patients in various stages of lung transplantation, which is a huge, huge credit to him, actually. When we still consider lung transplant in a very nascent stage in our country, and he has 200 plus. So that really means a lot. He's a part of the team to perform the first lung transplant in Gujarat on a foreign national as well as on an Indian national. And of course, his areas of interest are ILDs, lung transplantation, CLAD, and prevention of waitlist mortality. And finally, we have somebody all the way from Ranchi, Dr. Atri Gangopadhyay. Dr. Atri Gangopadhyay is again a very renowned pulmonologist from Eastern India who's been trained in interventional pulmonology at Mumbai, a brilliant fellow. great experience, pioneer of oscillometry in Jharkhand, and recipient of the Health Icon, Jharkhand Social Excellence Award, Jharkhand Raft Award, Global Business 2025 Awards, and so many others that probably is forgotten to even mention them here. So, welcome all of you this evening, and let's start the panel discussion now. The first question that I wanted to ask was to Dr. Nitin. That Dr. Nitin, of course, we've heard Dr. Uma describe all of parasomnias. For the benefit of the house, would you just like to, just once again tell us what parasomnias actually are?
I think, in a nutshell, I think Uma has done a brilliant job of doing exhaustive work, but at the same time, in a nutshell, these are unwanted, either behavioral or perceptional or dreams or whatever things which happen between the transition between wake and sleep state. And depending on REM or non-REM, they'll be divided. So I think these are events which are unwanted. That's first part. The second part is that they could be sensory, they could be motor, they could be behavioral, they could be dreams, they could be anything, and uh, and they happen in that transition zone between the awakeness and sleep.
Right. So, Dr. Supraja, I wanted to ask you that, as far as I think, probably all of us would have experienced some or the other kind of parasomnia at some or the other stage of our lives. So, it is really common, but how common is it in practice? How common is it that the patients actually come to you with the parasomnia? Can you unmute yourself, please? Can I request
Yeah.
all of you to unmute yourself so it'll be easy?
Yes. We had seen in the slides that the prevalence is around 50 to 60 percentage in children. The Indian data suggests that it is around 40% of children experience parasomnias, and especially children less than 12, the percentage is around 20. So if you ask a ballpark number of how many come to us, so predominantly it will be in people, I mean, in pediatrics. But when we do see cases with parents who are having parasomnias and their children manifesting with parasomnia, so maybe I would put it at my practice at around less than 2%, because it is from the parents and associated child who are coming in. And the distribution wise, predominantly, yes, it is going to be seen in children. And if you look at gender differences, so we see more of nightmares are common in female children, and RBDs are more common in males, and sleep enuresis has more predilection towards boys in the childhood. So this is the incidence or the prevalence that we see in our practice as such.
Right. So I guess it's more common in children than adults, but as they start aging, these parasomnias also start disappearing with time, except a few that can persist even after that, or some that occur in adulthood only, and we'll come to that subsequently. So, Dr. Kapil, I'd want to ask you that what are the normal and the abnormal REM sleep events, really, if you were to just enumerate them?
Okay. So, I mean, as it has been discussed, usually we pulmonologists usually see obstructive sleep apnea a lot. And, it's very simple for us to remember REM and NREM, the differentiation. Now, REM is rapid eye movement, usually approximately 2 hours of the total duration. Now, there are three characteristic things in REM. The first is rapid eye movement. Second is actually vivid dreaming. And the third, which is muscle atonia or muscle paralysis. Now, these three, the combination of these three is something which we call as the normal REM sleep events. Now, anything which occurs with contrary to these three is something which is abnormal. Now, most commonly, the abnormal REM events is related to the loss of muscle atonia or the loss of muscle paralysis. So basically, these people in REM sleep will start enacting their dreams. So this can be, simple movements such as talking, screaming, sometimes violent behavior like punching, kicking, or jumping. Now, usually such sort of a behavior is more commonly seen in males. It's almost 9 times more commonly seen in males as compared to females. And the usual onset is usually in the late 50s and early 60s.
Right. So, Dr. Atri, coming on to you, that what do you think is the pathophysiology? Of course, Dr. Uma did tell us some bit about it, but would you like to elaborate that what is the pathophysiology of the non-REM parasomnias?
As we found out in Dr. Uma's talk, that non-REM parasomnias are much, much more than REM parasomnias. So if I want to go to the pathophysiology, it involves combination of predisposing factors. The most important predisposing factors may be genetics. Someone with a family history of non-REM parasomnia increases the risk. Age of onset, more common in children and decreases with age. But people who had it in childhood can persist into adulthood. After predisposing factors, we will talk about sleep state instability like sleep fragmentation. Someone is unable to sleep for a long time due to loud noise, sleep apnea, sleep inertia, state dissociation. Other than that, there are certain precipitating factors that can trigger the episode. External factors like a loud noise, flash of light, disturbed sleeping environment. Internal factors like fever, a full bladder, BP fluctuation, hypoglycemic episode, and also sleep deprivation. Certain substances like alcohol and certain medications also. Thank you.
Right. And Dr. Uma, coming back to you, that what is the pathophysiology of the REM parasomnias now?
Yeah. Thank you for the question. So, as REM parasomnias are more pathological than non-REM parasomnias. Non-REM parasomnias are usually innocuous. I mean, we need not bother. REM parasomnias are many a times precursor for, later on being diagnosed with Parkinson's disease or Lewy body dementias, very, very rarely, even supranuclear, progressive supranuclear palsies. So they, proceed or proclaim that maybe later on, say even 4 or 5 years later, or sometimes even a decade later, that these patients can land up in a neurodegenerative disorder. So many times it is a leading into these conditions.
Right. So, Dr. Nitin, after having listened to the pathophysiology, the normal and the abnormal REM sleep events, I wanted to ask you that what are the confusion arousals and how do they usually present and how would you treat them?
In fact, confusional arousals are part and parcel of the non-REM. You can say it's the beginning of the whole story of, as Dr. Uma said, somebody gets up in a confused state in an NREM. This happens typically in the first half of the sleep. It happens in the deep sleep, that will be typically stage 3 sleep, and the person just gets up in a confused state and either goes back to sleep after some time. If this continues further, then you get the sleepwalking and other things. So I think that I'll leave that. But I think the confusional arousals are usually don't need to be managed in a very aggressive way, except for looking for the safety of that person. Apart from that, not much needs to be done. You generally don't need medications for confusional arousals.
Right. So, Dr. Supraja, would you like to tell us about sleepwalking, I guess,
I think that is the most
and how you would like to
commonest parasomnia that most of us would have heard, experienced, or seen. The prevalence is around 20%, less than 20% in children, but 7% of us globally would have experienced it at least one episode in our lifetime. So coming on to sleepwalking, is it that bad? In children, yes, the parents are going to be worried, but we need to reassure them and tell them that no, it is not going to be a problem. The child is going to outgrow it. And ensuring a safety in the bedroom, as mentioned earlier, with closing the bedroom doors itself and locking them. But there are children who can unlock the latches and still go out. But ensure that there are no other injury to the child when they are doing that. And sometimes the child will also come back and lie down into the bed naturally. So the parents can have a watchful thing whether the child is coming back, because if you wake them up in the middle also, there'll be a confusional state that can result in not knowing what is happening for them. So treatment wise, as we have discussed, it is going to be more of safety measures and find out why the child is having sleep deprivation or In children, usually they sleep around 8 to 9 hours. So, what is causing the disturbance in their sleep is something that we need to look into. We can put them through therapy or counseling. But if it is very disturbing, and the child is having recurrent episodes, though it is not going to be more than one in a night, but still, if it's going to be recurrent, persistent, then medications can help, like the benzodiazepines can help.
Right. So, Dr. Kapil, sometime back, I was reading a news article where there was this sexual offender who had committed a sexual crime and but could not be convicted because he proved that this was more of a parasomnia that he was suffering from, what we call as sexsomnia. So, is that really possible? Is that true?
Sir, it is very much possible, and this is a very important thing because this has got medical legal implications, as you just mentioned in the case. Now, sexsomnia, the literal translation is sleep sex. So this is a NREM parasomnia in which the patient unfortunately is engaging in sexual activities while he is in NREM sleep. Now, see, this is mostly diagnosed in males and in adolescents. Now, we need to understand what are the normal sexual behaviors. It can, have nocturnal erections, nocturnal emissions like sleep orgasms. But the NREM parasomnia, which is sexsomnia, can have a wide variety of sexual activities. It can range from masturbation to oral sex to intercourse with climax, even to moaning and dirty talking. These are all recorded in literature, and all of them are a part of sexsomnias. The worst thing is it's very difficult for us to differentiate between the two, whether it's an disease or whether it's a normal activity. And also remember, such patients will have their eyes wide open. So, sometimes the partner might actually quite get confused. Now, there are a variety of causes for it. It can be genetic, stress, alcohol, abuse, sleep deprivation. Drugs can cause it, and I was really surprised to read this, that the most common drug which is associated with sexsomnia is actually zolpidem. It's something which all of us quite commonly prescribe in our practice. So how exactly to diagnose this? Unfortunately, there is no 100% reliable test for us to properly diagnose this, but this needs a very detailed history. Like, the patient will have a history of some other parasomnia, there will be a family history. And most commonly these patients are very disoriented and groggy when you wake them up from such an episode. They might have amnesia. Obviously, when you do an EEG, like I mentioned, this is an NREM parasomnia, usually occurs in the slow wave sleep, as madam had mentioned in her PPT. And also, a full polysomnography sometimes is very difficult to pick this up, because it's not necessary that every time you conduct a PSG they will demonstrate such an event. So it is very difficult sometimes to diagnose this. And treatment, again, lifestyle changes, cognitive behavior therapy, and benzodiazepine, most commonly clonazepam, is what works in these patients.
Absolutely correct. So, Dr. Atri, I remember when we were children, there used to be this comic that used to come, Dennis the Menace. And in Dennis the Menace, they used to have this neighborhood uncle, Uncle Wilson, who in the middle of the night would go onto the refrigerator, pick up some pastries, pick up some cakes, and start eating them. And every time he would be caught by the wife, Mrs. Wilson, he would attribute it to that he was sleeping, and he just went and opened the refrigerator and picked it up. So again, asking you the same thing that I asked Kapil, that is that possible? Is that true, or that was just just a story fiction?
I had got a patient where very angry parents had brought their 12-year son, and they were very angry that this boy in the night goes to the fridge and eats up everything. And the boy used to deny all of that. So when I digged further, I came to know that there is actually a sleep related eating disorder which falls under NREM parasomnia. Now, sleep related eating disorder, person does not have any memory of eating during sleep. The person can actually cut the vegetables, cook the food during sleep, even wash the utensils and wash his hand or mouth. But the problem lies, there can be injury while cutting the vegetables. There can be burn injury while cooking. There can be aspiration problem, and hygiene means after eating, if the person did not clean the mouth properly, hygiene problem. And something very scary, poisoning. Suppose in the kitchen, because the patient is asleep, patient goes by reflex that where certain ingredients are kept. Suppose something poisonous is kept there, the patient can ingest the same. So sleep-related eating disorder exists. We don't know the exact incidence because many of these cases may not even reach a doctor. But if you ask me about treatment, sleep medicine is something where pharmacology is the last option. Initially, you need to think about sleep hygiene, documenting the sleep properly, behavior change, that if the partner locks the room while sleeping, these kind of things first. And only even then, if it is something very severe causing harm, then certain psychiatric medicines help, like something known as SSRI, SSRI, especially fluoxetine, femoxetine, certain drugs like topiramate, clonazepam, dopamine agonists like pramipexole. So these are certain medicines which have been tried. Rare, interesting, complex to treat.
Right. Dr. Uma, you did show us a video on sleep terrors. Would you like to again explain once that how do the patients usually present and how would you really treat them?
Yeah. No, I had once a patient, they had come all the way from Kolkata. So this was a 9-year-old boy where the mother was very anxious. Like she was sleeping next to the boy, and suddenly she heard him screaming, and it was uncontrollable, and he was crying. He even walked a few steps from the bed, and but he was inconsolable. So she was claiming that some tantric thing has happened, something has happened, and then finally they sought medical attention. So this is how a sleep terror usually manifests. They'll have sudden piercing scream, and they have lot of severe anxiety, tachycardia. They can have manifest as tachypneas. Many times these children are unarousable. They even attempts to wake them up or trying to calm them down, it might actually precipitate or cause it to happen more. So that is the usual uh, manifestation of a terror. Usually occurs in the first half of the night. So during the sleep, deep sleep, entry sleep. Most often treatment is nothing but reassurance or sometimes timed awakening. Like for example, if the parents have noticed that it occurs, say particularly at 11 o'clock, by 10:30 or so, make sure that they keep an alarm and wake up the child. Make sure that the child responds with the verbalization and then allow the child to go back to sleep, then usually nothing happens. But if it is very severe and occurring very frequently, more often, then pharmacological therapy, like others like clonazepam or melatonin, will help. Thank you.
Right. Dr. Nitin, so what is this REM sleep behavior disorder?
Yeah, I think REM sleep behavior disorder, as it is something which happens during the REM part of it, and invariably there is something called as the enactment of the dreams. So that means the first part of it is that the atonia has to go away, because REM is typically associated with rapid eye movement and paralysis of the body. Here the body paralysis goes away, and therefore there is enactment of the dreams, and that enactment of the dreams leads to sometimes very violent things. In fact, I have myself broken a glass once in a REM's parasomnia, and that was when I was doing critical care. And the best thing I did was I stopped doing critical care and went into interventional pulmonology, and I'm much happier. So I think the stressors maybe the ones which have to be removed. If that cannot be done, then the drugs have to be used. But I think the essential idea here is these behavioral disorders are associated with enacting, and enacting sometimes can be also injurious to the partner. Luckily, I've never hit my wife in that kind of a way ever, but at the same time, I think they can be dangerous to the bed partner also. So one has to be very watchful of these. And the other part is these will be memorized. because because they are not like in NREM. NREM sleep parasomnias are not never almost not memorized, whereas this the person remembers what he did, and that's how we differentiate.
Right. Now that's what I feel, that sharing your own experience, first-hand experience, is very, very essential sometimes. So, Dr. Supraja, how would you classify these REM behavioral disorders and how do you diagnose them truly?
So REM can be either idiopathic, where there is no underlying cause. The other one, as was discussed, the secondary RBDs can be because of it can be like a heralding thing for a neurodegenerative disease. So whether you have a REM sleep disorder, following which after many years you develop a neurodegenerative, or is this a predisposing factor? We are not sure. So it is kind of associated, and there are certain medications which can be causing our REM sleep disorders. This medicines, it can also be triggered by antidepressants. Sometimes beta blockers can trigger it. So diagnosis is mainly through history, where the partner comes. In fact, we had a colleague or a senior in college who had a REM sleep disorder, usually presented with enactment, and we were. Initially, we didn't understand. We were, though we were all medical students, but we didn't understand that this was a sleep behavioral disorder that was happening. It took us many years, and during post graduation is when we understood that she needed to be addressed by the sleep specialist, and got sorted it out. So again, history from the partners, because we used to get scared and not tell her, thinking that it will affect her, which is also very, very common, naive, because we were young. Second thing is clearly demonstrating it in polysomnography if possible. As we have discussed, it's not going to happen every day, but if you are able to demonstrate atonia, absence of atonia in the polysomnography, then that is going to be classical. And demonstrating the other complex behavioral behaviors during sleep. And the other most important thing is also to rule out other causes like OSA, epilepsy will also be ruled out when you're doing your polysomnography. And questionnaires, myosleep questionnaires. So if we are not able to do a PSG, at least these questionnaires can help. Basically, like as ma'am said, the single questionnaire or the REM sleep disorder screening questionnaires can help. It's a 13 item questionnaire. The higher the number, the more the chance of having a REM sleep disorder. So that's how we can identify it.
Right. And how would you manage it, Kapil?
So before I answer that, may I just mention that it was very magnanimous and gracious of Dr. Nitin sir to narrate his incident live on a webinar. And if we actually pay attention to what he mentioned, it very much forms a part of the management strategy. Now, there are 4 management strategies for REM sleep behavioral disorders. The first is you need to have a safe environment for the patient. Now what all should we do? First of all, remove all sorts of sharp objects in the vicinity. You need to use headboards, nightstands. Sometimes you need to surround these patients by pillows, and also you can keep a mattress just below the bed. So you need to create a safe environment for this patient. Second is lifestyle changes. Now, as sir mentioned, he just switched over from critical care medicine to interventional pulmonology, basically more regulating the sleep cycles, regulating sleep timings, avoiding alcohol. We unfortunately live in a very dopaminergic toxic reality in which all of us want our mobile phones every single time. So if we have basic sleep hygiene, this will also contribute a lot to management. Third is, as everyone has already mentioned, we need to keep a close watch for the development of neurodegenerative diseases in these patients. Now, it is said that in the next 14 to 15 years after a basic diagnosis of RBD, there is a 30% chance of these patients developing something like a Parkinson's or a Lewy body dementia. So we need to keep a track on this. And last is, as Atri mentioned, sometimes medication should be the last which is offered in parasomnias. So There are some drugs which have shown to be of some benefit. Melatonin, clonazepam, and pramipexole are the top three out of them.
Right, very good. So, so far we've only been talking about the activities that you can, the actions that you can do while you're sleeping, like talking, walking, sexual crimes, sex, eating. But one thing that can be very scary is the feeling of paralysis. That you're sleeping and you suddenly feel you're paralyzed, you're not able to get up. So, Dr. Atri, would you like to tell us a little more about it? And how would you manage a situation like this, where patients just come to you, say that, they were sleeping and they realize that there's something happening, something around them, something very scary happening, and they were unable to respond?
Isolated sleep related paralysis is something very real. And if someone is sleeping alone, it can be very frightening that the person may start developing a fear of falling asleep. Because if someone is unable to get up from the bed even after waking up, someone is unable to call someone even on waking up, it can be very, very scary. Again, before the treatment, we must try to understand whether there is any underlying neurological cause. These disorders developing suddenly in a mature person can indicate some serious neurological problem. It can be some ischemic problem that did not result in a proper CVA. It could be some underlying tumor. It could be some aneurysm compressing somewhere. So get a proper neuroimaging, get a proper neuroconsult. After that, do a proper sleep study. Even then, if you can't pinpoint a cause, only then we shall label it as a proper parasomnia. And again, sleep hygiene, avoid sedatives. Sedatives, due to their fluctuation of dopamine, can trigger parasomnias. And again, if you need to come to pharmacotherapy at the end, you can again think about this tricyclic antidepressant TCAs like clomipramine, imipramine, and a little bit about SSRIs. But again, there has been no magic bullet. Like in the various studies, the drug versus placebo has not shown very significant improvement. So there is no wonder pill for this condition yet.
Yeah, thank you so much, Dr. Atri, for a very detailed response to this question. And so, Dr. Uma, I think nightmares is something that all of us would have experienced at some stage or the other. As long as it is a dream, it's okay. But when it turns scary and it wakes you up suddenly, it can be really very disturbing sometimes. So, would you like to elaborate more on them?
Yes, rightly said. All of us would have experienced one time or the other terrible nightmares. So nightmares are like really vivid dreams, and usually many a time those are negative thoughts, like in the sense where it's like frightening, and like person is being attacked and they are defensive. Either they are defending themselves or the family members, such things like that, or they are falling from heights. And in literature there is a evidence where person, he had recurrent nightmares of as a swallowing snakes. So because of this he was even afraid to fall asleep. So it can be so severe that it disturbs regular sleep and day to day activity. But of course, nightmares are something which can be addressed. There is something called as image modification therapy, where if a person has a very severe affection because of the nightmare, and it is causing their daily life a difficult thing to live, you can instruct them like at what point of the time does the dream become from a positive to negative aspect, so they can actually image or try to imagine what is happening, and that particular point where it becomes more negative, try to actually image or try to imagine a positive aspect or continuum of the dream, like your whole drama is happening in the brain and then that is continued, so that they have to train themselves and then they can even write it down, and then it becomes better. So that is one aspect. And then there are other this thing like mindfulness, meditation, and then cognitive behavior therapy. If all of this doesn't help, there are certain drugs also which can precipitate nightmares. For example, very commonly we use Montelukast. So, as pulmonologists, all of us have prescribed Montelukast, but it is very well known to precipitate nightmares. So, certain other neurological drugs also can precipitate nightmares. So, we have to be very careful in how we are prescribing that. So, to avoid that, of course, treatment can be again clonazepam or melatonin, which will help in reducing the nightmares. Thank
Yeah,
you.
I think this is a very important point that you've highlighted here, that Montelukast, a medicine that we write left, right, and center to our patients, can also result in nightmares. So very, very important. So, Dr. Nitin, from a stage of sleep paralysis, from a stage of, say, sleep anger, sleep terror, where it's more of protective and not as much of medication that is required, what would you want to speak about hypermotor epilepsy? How would you diagnose and treat that?
I think it's a very tough question to sort out, because previously it used to be called as frontal lobe, but now I think it is better described as hypermotor, and sleep. It happens in sleep essentially. Uh, it has to be differentiated from the non-REM movement disorders, and that is very important. The myoclonic jerk, hypnic jerks, and all that have to be separated. And as Dr. Uma very rightly said, that if you are getting epileptic movements, they will be repeatedly absolutely the same type, whereas the non-REM parasomnias will be different every time. They could be little different one way or the other. And of course, I mean, you have to document them and treat them as epilepsy, and that is going to be the important part. It would be a little tough, and you may have to combine both the techniques of neuro workup, the EEG part of it. EEG may or may not be abnormal. In around 50% of the cases, the EEG is normal. So that also may add to your difficulty. So daytime EEG is not necessarily abnormal in these patients. So that creates extra difficulty. But I think once again, very good history and very observant bed partner. I think these go a long way in getting the diagnosis right, and eventually you are able to sort it out. And that very typical repetitive same type of movements, that history point is very, very important. That it has to be the same thing, then is more likely to be epilepsy rather than any of those non-REM parasomnias, which also lead to movement disorders.
Right. Thank you. Dr. Supraja, do you think there are any situations where people could be hearing loud sounds also, besides the action and everything else that they could be doing in the night? But could they be hearing some loud sounds, or what is called the exploding head syndrome?
Yeah, it's one of the very rare parasomnias, where the differentiating thing should be from confusing it with migraine or some ENT issues, because here the patient will experience or hear loud sounds while going to sleep or waking up, but it is not going to be associated with pain. So that is very, very important, because in migraine, again, we have flashes, we do have hearing sounds, or experiencing pain. That is the main differentiating point. Not much reported. The prevalence is around, the cases reported are all sparse, less than 2%. Not much of a gender predilection as well. But what we need to understand is it is more associated with insomnias, depression, anxiety, psychological issues. As we are discussing in the current age, there are a lot of people who are having insomnias because of a lot of reasons. One, predominantly because of shift working and excessive usage of devices. So the Gen Z is experiencing more than 40% parasomnias compared to what we had during our days. And when it compares to shift workers to regular workers, there is a 3 times increased observance of parasomnias that is happening. So these things can be possibly, it will be much more seen in the coming years with the change in lifestyle that is happening. So again, education explaining to the patient that this is, first we need to understand and then explain and reassure them, and mainly address the sleep deprivation. That is more important to possibly, make it go away.
Right. Dr. Kapil, one common complaint that patients, especially of parents of children, do come to us saying is that the child continues to pass urine in bed at night, what is called the sleep enuresis. So, would you like to elaborate on that and how to treat that really?
Sir, as you rightfully mentioned, so sleep enuresis is nothing but the act of urinating, during your sleep. It's also known as nocturnal enuresis, and rightfully, as you mentioned, it's the parents who primarily come to us because this is, it affects children. Now, up to the age of 5 to 6 years, this is considered to be normal because that is the time when not only their mind but also their bladder and everything will be, there'll be some sort of a coordination and there'll be some sort of a training going on. But if this occurs beyond 7 years of age, especially the criteria is more than 2 episodes per week occurring for more than 3 months, then we are staring at a problem. Now, as you mentioned, at least 80% of this happens in children, but there are also such cases which are seen in adults, which is known as secondary enuresis. Now, what can be the causes because of this? It's a simple demarcation. It's either a medical or a psychological. Now, medical reasons actually include urinary tract infection. There can be stones. There can be diabetes mellitus. There can be chronic constipation, OSA. And sometimes people do have small sized bladders. It's more of an anatomical thing. So these are the medical reasons. Psychologically, it can either be ADHD or there can be some sort of a stressful response. Now, how do you manage this? Of course, if you've got a medical condition, you need to manage better. For example, if you've got diabetes, you need better glycemic control. If you've got UTI, it means you need antibiotics. Stones means you need a urology reference. But most important is habituating such children. So simple acts of decreasing water intake, especially post evening. You need to go to the washroom before going to bed. Some parents actually also use nighttime alarms. 2 o'clock or 3 o'clock, they'll actually get up, wake their children just to go to the toilet. And you need to incorporate so many behaviors so as to improve the condition. As far as medications are concerned, now this is a condition in which you need anticholinergics, so such as solifenacin, oxybutynin. So these are anticholinergic medications, I'm sorry, which will decrease the bladder contractions, and they have been used in a variety of these conditions with great help.
Right. So, one other very, very common entity, I think that probably many of us would have experienced it in the night, either yourself or with your children, is talking while you're sleeping. Now, I don't know when you're talking, whether you're actually talking sense or you're just talking irrelevant stuff. May I request Dr. Atri to tell us more about this?
When I was a kid, my parents used to say that I used to solve numericals in my sleep, or I used to repeat multiplication tables in my sleep, although I don't have memory of the same. And
Wow,
nowadays, I
that's
get
fantastic.
patients where married couples come to me that where either the husband was taking names of multiple females in sleep, or the wife was taking names of multiple male in the sleep, and it used to cause some kind of domestic discord. The technical term for this is somniloquy. Most often, the conversation is very muffled, means the patient makes unintelligible sounds which may not be discerned. But sometimes, due to loss of inhibition of whatever neurons in the sleep, the patient can become very abusive during sleep, using really filthy language, threatening someone, and that someone may be a family member or an in law. And this can be very distressing. Obviously, the sleeping partner here will seek help from the doctor. Again, this is the condition where there is actually no medicine involved yet. Please do a proper sleep study, including videography, to confirm regarding the REM, NREM, number of arousals, whether there is sleep fragmentation, whether to treat any OSA or not. Other than that, review the medicines, because interruption of medicine again by exciting that serotonin, dopamine can cause this problem. So review of any neurogenic, any sedative, any antipsychotic medicines. Sleep hygiene, that immediately after a heavy dinner don't try to sleep. Definitely no alcohol before going to sleep. So these are some things which may help. It can be distressing, it can be humorous, but fortunately, it does not kill like the various parasomnias you have discussed before. Thank you.
Right. So as I said in the beginning, guys, that parasomnia is something that all of us have experienced in our personal lives sometime or the other. Just that, you may not be able to recollect right now, or you may not be wanting to speak about it right now. But yes, it is something very common. And I forgot to mention that Kapil Iyer also runs a channel on YouTube, the Detox, which is really very interesting. And if you people get time sometime, you must log in and watch that too. So, Dr. Uma, now coming back to a very basic question, or before that, let me ask Dr. Nitin that Dr. Nitin, Dr. Atri was also talking about video PSG. So, when is a
Yeah.
video PSG indicated in a patient with suspected parasomnia?
I think more often it is really futile if you really ask me, because what you are looking for may or may not happen in that predictable way. If something is happening every day, for example, whether it is REM or non-REM, and then you are doing a full night video PhD, it will be definitely be able to pick up with a high chance of that being picked up. But a simple video surveillance camera may be much better help. In fact, I have a humorous episode to share, because one of my very old relatives was being accused of not sleepwalking but going into the fridge while going pretending to be going to the toilet, and eating the cakes or whatever they were in the fridge, and then without anybody's knowledge, and there was an attendant also there, and then they just put in a video surveillance camera, and that attendant was the one who was stealing these things, and he was accusing the old man of doing it. So a simple video surveillance camera can be of much better help in parasomnias of both REM and non-REM, because rather than doing a complete EEG, of course, when it is possible and when it is doable and when it is repetitive, when you know it is very likely to happen, yes, I will do a full video PhD, worth it. But just a video camera being there in the night with which is watching all the time can pick up most of these events beautifully.
Right. Dr. Nitin, I just want to say that, your background is really very impressive. I think it's just been recently inspired by Shubhanshu Shukla's visit to the space. So, Dr. Uma, now coming on to a very basic question, that how do you really diagnose parasomnias?
Yeah, I think after all this discussion about REM parasomnia and non-REM parasomnia, diagnosis is very important. I think the very clear answer is history, history, history. So, a very detailed and important, clear history and description from the bed partner or the parents or the family members who have actually witnessed the event goes a very, very long way in diagnosing these events. Said that, um, there are certain instances where you would still want to do a polysomnogram. So these are very few instances. But most often, when we have a very properly described event by the observed by the bystanders, that is enough for us to diagnose these conditions.
Right. Dr. Supraja, we have lots of questions in our chat box also. So I'd
Yes.
like to request you to quickly tell us that how do you treat non-REM parasomnias?
It's going to be multimodal approach. First, as described, the environmental measures, safety measures have to be put in place. Second is identifying comorbidities and treating them. OSA, epilepsy, psychiatric illness, all those have to be addressed and not put into treated as parasomnias. Then we'll have to look into medications. If it is very, very severe, medications as discussed, benzodiazepines, melatonin can help. And therapeutic, like I do a little, little bit of work on pulmonary rehabilitation. So cognitive behavioral therapy really helps for patients who have a borderline mental health issues as well, and those who it can reduce the triggers, anxiety, PTSD, and it will improve the overall sleep quality. So basically, a combined multimodal approach will be much better than just saying that okay, reassure and okay, boss, you can go back home. So I think everything in that particular patient has to be addressed and sent.
Right. Kapil, tell us about how you would want to treat REM parasomnias quickly.
Sir, under four headings, sir. First is, as ma'am mentioned, safety of the environment and safety to the patient is absolutely paramount. Second is you need to treat the underlying cause. So the cause can be anything. It can be a medication. Ma'am just mentioned that Montelukast also is one of the offending agents, something which we use left, right, and center. Narcolepsy, OSAs, chronic pain. So whatever underlying cause which you have, you need to redirect your treatment towards that. Third is, it's basically lifestyle changes. So you need to improve the habits of the patient. So regularize the sleep wake cycle, the sleep wake timings, sleep hygiene, and cognitive behavior therapy, as Supraja ma'am has just mentioned, will also work over here. And last is medications. Now, out of that, SSRIs, melatonin, and also in some cases, tricyclic antidepressants will also work.
Right. So, guys, sleep is something that we've always considered as a very passive state, that you're just lying down in bed sleeping. But I think after all the parasomnias we've discussed, you would have realized that sleep can also be so action packed. And, when it is action packed, some of these actions harm the individual, some of the actions harm the people around them. So, Atri, what would you like to tell us about the medical legal implications of sleep parasomnias?
If there is a parasomnia diagnosed in the family, other family members must become paranoid regarding that night. There has been a very sad incident where someone in the United Kingdom, in sleep, drove 2 kilometers to murder his mother in law, almost murder his father in law, and come back, got arrested, but the insurance paper documented the parasomnia and the person was acquitted. Now, whether it was premeditated or whether it was disease, that is something very difficult. So, three legal situations arise. Someone actually did a crime with premeditation and attempted defense that it was a part of a sleep disorder. Second situation, person actually had a sleep disorder and committed the crime. Third situation, or employer liability, that someone employed a person in a high risk job who had a sleep disorder and the person created an accident at that workplace. So, when such a crime occurs, since the person will be arrested, it's very difficult to recreate a sleep to see whether the person again moves about in the sleep or not. But any past medical record, any past insurance record of a sleep related disorder is very important in helping the defense of the person. So, if there is any parasomnia you diagnose, please document it. Please inform the insurance company and please inform the employer of the person so that these legal consequences, if arise, can be taken care of.
So what you're actually trying to say on a lighter note is that if you want to commit a crime, first go and get yourself declared that you have a parasomnia, sleepwalk or something. And then probably there's a chance that you may get acquitted of the crime that you want to commit. Anyway, this was just a joke, guys, not that you have to take it seriously, huh? So this brings us to the end of the questions that we had for our discussion, but we have a barrage of questions in the chat box that we still need to answer and a long way to go ahead. So let me start with Dr. Uma itself. Dr. Uma, first question to you. How do you clinically approach a case where a patient reports violent sleep behavior during disorder? This is a question from Dr. Kamal Gandhi from Ahmedabad.
Okay. So if there is a violent behavior noted during a sleep episode, first we'll have to delineate whether it is a non-REM or a REM parasomnia. So that will depend on which part of the night is the episode occurring, whether it is the first half of the later half, and what type of violent behavior was it. Is it just shouting? Or is it movement of the hands? Is it some hitting themselves or the bed partners? So that will help us to differentiate. Sometimes, very rarely, even epileptic seizures can have these type of movements. So if we see that it is a stereotypic movement, in the sense very uh, similar type of movements are happening at every episode, it suggests more of epilepsy rather than a parasomnia. So we have to differentiate between epilepsy, non-REM, and a REM parasomnia. Usually REM parasomnias are depends on the age also. They are more seen in elderly, I mean not elderly, like middle-aged to elderly males, and uh, usually in the later half of the night, they can last a few minutes longer than what non-REM parasomnias. So based on these particular history, we'll be able to actually more or less delineate what sort of a parasomnia it is.
Right. So, Supraja, Sanket Kadam from Mumbai would like to know that what's the link between PTSD and parasomnias like nightmares or REM related behavioral disorders?
Any sleep deprivation. So PTSD is going to produce a lot of sleep disturbances and difficulty. So that can trigger parasomnia. So it can be predominantly a RBD in the second part of the night. That is because they're going to keep the memory will keep visiting the same part where it is injured. So it goes round and round about it like a loop. So it is associated. So PTSD is one of the things. So we need to identify. So that is why the history is very important in digging deep as to why the sleep is getting disturbed, whether it is children or adult. We need to find out, and if there was any assault or sometimes it is better to ask the patient alone because they might not be forthcoming with the history. So we can find out PTSD, especially in females, adolescents, where this can be very common, and find out there is a link definitely between parasomnias and PTSD.
Right. Dr. Kapil, Dr. Mohan from Bangalore wants to know that how is REM sleep behavior disorder associated with Parkinson's or a Lewy body dementia?
First, it's very important for us to know that yes, there is a very strong association. As I mentioned, once an RBD is diagnosed, in the next 15 years, there is a more than 30% chance of these patients developing a neurodegenerative disorder. Most commonly is Parkinson's. However, the exact mechanism for this for it is not known. It's the most commonly hypothesized thing is there are issues with the locus coeruleus in which there are misfiring of neurons. So that is the most common hypothesis which associates the REM sleep behavior disorder with the neurodegenerative diseases.
Right. So, Pranav, you were telling us about sleepwalking. So, Dr. Vivek Kaur from Lucknow wants to know that how common is sleepwalking in adults and when should it be considered pathological?
Question is to me?
No, to Dr. Supraja.
Oh, okay. Sorry, I didn't hear the name. Sorry. In adults, so usually in children, the sleepwalking is going to be around 17%. But as we are growing up, it comes to less than 2%. Still 2%, if you're considering it in a huge population, it can be many. But pathological is once it is going to be harmful and it's going to be a repetitive event and they are going to injure the bed partner. That is when we need to consider it.
Right. So, Dr. Nitin, that there's a question from Dr. Jaya Sanjeevani from Bangalore again that can parasomnias be misdiagnosed as epilepsy or psychiatric disorders? And how would you really differentiate them?
Yeah, I think the epilepsy part is very, sometimes can be confusing, particularly if the convulsions are happening only during the sleep. Then it is more difficult, and they're very occasional. Again, then it is more difficult. But I think there are some clues, because epilepsy at least once in a while will happen during the day also, whereas all the parasomnias will occur only during the night or the sleep hours. So that is one part which will help you differentiate. The second part is, of course, if you are lucky to record an abnormal EEG, fantastic, wonderful. That sorts out that is an and it's showing epileptic form abnormality. Then I think that makes it easier. There's a second part to it, which the psychiatric disorders. I'm not too sure on that, very frankly, how you are going to differentiate between a psychiatric disorder and this. If somebody has any other
I want to put a quick comment here. There is a
Yes,
psychiatric disorder known as multiple personality syndrome. Sleepwalking, sleep talking, and violence during sleep have been recognized as part of this multiple personality syndrome. In multiple personality syndrome, they use something known as hypnosis or hypnotism, where one personality is suppressed and the hidden personality comes out. So these parasomnias can be a portion of this multiple personality syndrome.
So Dr. Jekyll and Hyde.
Truly. So, Dr. Uma, Dr. Ramesh Torani from Nagpur wants to know that what are the key differentiating features between non-REM parasomnias and REM-related sleep behavioral disorders?
I think this has been discussed many times.
Yeah, could you just
That's what
highlight the points?
Yeah. Just to highlight the points, non-REM parasomnias, the timing when it occurs, usually more common in the first half of the night when the person has N3 sleep. And these can be disorders of arousal, like they can have sleep walking, sleep talking, confusional arousal, sometimes very rarely sleep terrors. So these are non-REM parasomnias. And even during the sleepwalking or sleep talking, they sometimes, very, very rarely, they can have, like abusive language or hitting themselves or the others. So even injury and stuff is possible here. But this is more evident in REM parasomnias, where this is associated during the REM sleep. So more common in the later half of the night and more common in the adults, whereas non-REM parasomnias are more common in children. And during the REM parasomnias, they can have like either they are dreaming that they are being attacked, so defensive, or they can attack others. So dream enactment happens. So they will literally enact or do the movements what they are actually dreaming up, and so end up injuring themselves or the bed partners. And REM parasomnias can be a precedent or can proclaim neurological disorders later, like Parkinson's or Lewy body diseases.
Right. Dr. Atri, this is a very interesting question that has come from Dr. Shiprasad from Aurangabad, that a 40-year-old male having choking sensation only while falling asleep. A polysomnography is done which shows mild OSA, but he does not benefit with PAP therapy. So can these be hypnagogic parasomnias?
This can be something known as hypnagogic parasomnia if there is no improvement after PAP. Secondly, this can be that isolated sleep-related paralysis also, that when during arousal or awakening, a paralysis hits the person, because only then the person will be aware of the choking. During sleep, if choking occurs, person may not be aware of it. Third thing, there is something known as bruxism, which is very common in children. Now, if some sort of bruxism persists to adult, that tightening of the jaw during sleep, that tightening pressure can also radiate to the neck muscles, leading to the choking feeling. So, other than hypnagogic parasomnia, also think of sleep-related paralysis, extension of bruxism also.
I
Right.
would
Very
like to,
interesting. I think you
yeah, I would
highlighted
like to
very good.
add on to it, saying that being pulmonologist, I think we can also do a dice to find out if if there's any muscle, a level of obstruction which is happening in the upper airway levels.
Right. Just who was handling the non-REM parasomnia? I think it was Supraja, right? Yeah, Supraja, again, the question is for you only about the non-REM parasomnias. This question comes from Dr. Devpriya from Kerala. What are the neurobiological mechanisms underlying non-REM parasomnias?
I think ma'am went through it with all the centers which are getting central parameters which are getting stimulated during sleep. And it can be either in the central level or in the spinal level where it is getting stimulated. And that is how it happens. So I think it was a very clear slide that she had mentioned.
So Dr. Kavita Gopal from Tamil Nadu, Chennai, Tamil Nadu, sorry, has said that, ma'am, wonderful teaching, thank you. Except that she hasn't specified which ma'am, or is it both the ma'ams and not the sir?
Teaching is Dr. Uma, sir.
Right. That's okay. So as I said in the beginning, Dr. Uma has a huge following. So again, Dr. Atri, coming back to you, Dr. Jai Kishan from Punjab, Patiala wants to know that what are the legal importance of injuries during sleep disorders, sex violence or divorce?
Sex violence can unfortunately cause arrest outright and immense loss to reputation. So, if someone has such an issue and someone is, let's say, not sleeping with partner, in a certain situation. It can be in a train, sleeper class of a train. A person is sleeping there and such a thing happens. So lot of distress can occur. So there is legal implications. So again, I would want to reinforce, if as a psychiatrist, if as a pulmonologist, if as a physician, you pick up a parasomnia, please document it. Please explain the nuances of it to the family. And please inform the insurance company that whenever such an unfortunate incident happens, so that a victim does not get shamed. The patient here is also a victim. And again, if there is no such documentation in a country like India, it will be very difficult to defend someone as a new onset parasomnia.
So next is a question from Kapil to Kapil. Kapil, so be ready. This is from Kapil Singh from Chandigarh. What are the most common triggers or risk factors you've observed in patients with recurrent parasomnias?
Sir, in my practice, the most common I've encountered, even though my practice is not primarily sleep, less than 2% of my practice is what I see in sleep and parasomnias. Most common two things which I have personally encountered is number one, a stressful event, PTSD or a stress, and number two is basically alcohol abuse. So a lot of alcoholics sometimes present with parasomnia. So in my practice, I have seen that these are the two most common reasons why people will come with recurrent parasomnias.
Right. Dr. Nitin, coming on to you now, there's Dr. S. Ahmed from Salem, Tamil Nadu, who wants to know that sudden arousal followed by hyperventilation. Could this be a parasomnia or just generally? Sudden arousal followed by hyperventilation.
From hyperventilation or hypoventilation?
Hyper.
Sudden, I think he's talking about a RERA-like phenomenon, possibly, respiratory effort related arousal. So that will be more into obstructive zone rather than a parasomnia.
Or maybe just sleep anxiety.
And of course, I mean,
if it's not a sleep terror, then just an anxiety.
Yeah, I mean, if it leads to it, it could be a trigger, and it could lead to. But I don't think I have seen so many. I mean, we see a lot of obstructive sleep apnea. Very rarely you see a RERA related or RERA triggered parasomnia.
Right. So Dr. Kiran from Ludhiana wants to know that could there be a genetic or a familial predisposition also to parasomnias?
Yeah. Actually, the non-REM parasomnias have some element of genetic predisposition. Many of these people who have parasomnias have family members who have, like, for example, parents might have had parasomnias or siblings might have. So there is a genetic component. Few chromosomes also are known, but it is not very widely studied, and it is not very well studied in India as such. It is definitely there.
Right. So Dr. Supraja, Dr. Devpriya from Kerala wants to know that how does alcohol or sleep deprivation influence the frequency of parasomnias?
So we did notice that parasomnias are predominantly because of sleep fragmentation. So in alcohol abuse, sleep fragmentation both in the REM and the non-REM phase starts increasing, and the quality of sleep also is very poor when they are having alcohol. So generally during sleep deprivation, either due to shifts or extended shifts or reasons for in the current Gen Z not sleeping well. So that will again produce a sleep fragmentation. Now that is going to increase the occurrence of a parasomnias, and then the repetition can keep increasing. Frequency will start increasing.
Right. Kapil, this is Dr. Nirav from Gujarat, Surat, who was actually complimented that good evening and to all this, and thank you for sparing time.
Thank you for sparing time. Yeah, it's more of a comment.
So next question is from Kumar Gaurav Gupta, who's a pediatric pulmonologist in Uttar Pradesh, Moradabad. And his question is, how does REM atonia loss lead to REM sleep behavior disorder?
Okay,
so sorry, yeah, go ahead.
So as I mentioned previously, so the characteristic of REM is three things. So number one is you need rapid eye movement. Number two is you need vivid dreams. And number three is you need a muscle atonia or a muscle paralysis. Now, REM sleep behavior disorder is when the third point is affected. That is, the muscle atonia or the muscle paralysis does not occur. So the patient or the person who's affected starts enacting his dream. So, as I mentioned, this can be, this can be vocal implications, this can be kicking, this can, in very, this can be like hitting, arm flinging, very severe cases, it can be jumping. So that is the characteristic hallmark of REM sleep behavior disorder.
This question has come from Dr. Hira Dalodria from Madhya Pradesh. Kapil?
So, sir, so there are two questions. I would just like to take both the questions by Dr. Hira. First is, what is the role of melatonin in treating REM sleep behavior? Now, I have to mention over here, there is no US FDA approved medication for REM sleep disorder. And I'll again echo what Atri said. Usually sleep and parasomnias and sleep related problems, medication usually is the last. One of the first things which you actually have to concentrate on is sleep hygiene and lifestyle changes. Now, melatonin as a drug, we all know that melatonin is a hormone which is secreted by the pineal gland. The usual function of melatonin is basically to regulate the sleep cycle. So that is one of the paramount pharmacological interventions which is needed as a lifestyle modification to help in sleep behavior disorders. And the second question which he has asked is are dreams good for mental health or bad? Now, I'm not very sure. I mean, I don't think so. Dreams have got any association with the mental health. I mean, all of us will dream. It's something which is not in our control. It's something which is extremely normal. So I think people having dreams is something which is extremely normal. It's just normal for mental health. Now, this becomes a problem, obviously, when you have something like sleep terrors, as Uma Madam mentioned in her PPT, or nightmares or something. That extreme is something which you will actually categorize as parasomnias.
He has another question for you. Role of desmopressin in bedwetting, enuresis.
So, sir, in this, I would like to mention that, as I mentioned, enuresis can have two basic etiologies. One can be medical, one can be psychological. One of the points in the medical part is basically decreased in vasopressin, because of which there's a lot of fluid accumulation and the patient will actually bedwet. So desmopressin actually acts by normalizing the level of vasopressin, and it can be one of the modalities, but you need a proper endocrine diagnosis of problems in your vasopressin secretion. Only then will desmopressin help.
We have endless questions. I don't know when to stop. But Dr. Ajay Kumar Srivastav has asked two questions on anxiolytics and insomnias. So we'll skip that because I'm sure there's a whole session that will be dedicated to it. PTSD and all we've already discussed. Now, what about chronic illnesses? Dr. Nisha Negi wants to know that what is your treatment algorithm for chronic parasomnias, and do you prefer pharmacological or behavioral approaches? So I think we've all discussed it, that behavioral approaches is what is necessary, and if it doesn't come under control with that is when you resort to pharmacological therapies. Otherwise, most of these can be innocuous, occasionally result in serial complications.
And I think possibly, even if you are medicating, the other cognitive behavioral therapy and other things have to continue. The lifestyle changes which are wanted should be continued. The sleep hygiene part should be continued. So it's not at the exclusion. The drugs are never the magic bullet in this kind of a situation.
So
we
Dr.
must
Vinod Ramane from
remember
Mumbai is also
that
talking about the same thing, benzodiazepines or behavioral therapy. I guess it's a combination, as Dr. Nitin also said.
I want to add something. We must remember that these neurotransmitters have a very narrow safety range. Less neurotransmitter, not good. Excess neurotransmitter, not good. Chronic use of certain neurotransmitter, again, not good. So only when there is a risk of safety, please think of pharmacology. Long-term treatment has to be that behavior therapy. Whenever you have diagnosed a parasomnia, try to involve a psychologist with you at the earliest.
Right. Dr. Uma, so there's a question from Dr. Jamal from Kanpur, that what role will sleep hygiene play in managing complex parasomnias?
Yes, a very relevant question. Sleep hygiene is very important. As we saw, the predisposing causes, or sometimes it can precipitate whenever we have a poor sleep hygiene, like a person has not slept properly or sleeps very late, there is a disturbance in the circadian rhythm, or sleep environment is not conducive to sleep. For example, it is excessively bright, or there are loud noises, some disco or something is going on, and then that is disturbing, or sudden loud noises also. So all these can be precipitating factors for parasomnia. So sleep hygiene is very, very important, as important as your previous question also. When a person is on pharmacotherapy, do other modalities stop? No, never. So it is always a multi-modality treatment. Both sleep hygiene is very important, protecting the patient, and pharmacotherapy. Everything will go hand in hand.
So after all the appreciation for Dr. Uma, there's somebody who's liked my moderation also, huh? Dr. Jayesh Bhalerao from Mumbai,
Yeah.
who so far had only heard me on the various conferences, but somehow has found my moderation very wonderful. Thank you so much, Jayesh. And I
You're
look
doing
forward
a
to
very
seeing
good
you at
job.
some point.
Yes, there are two
Absolutely, you are doing a
languages.
wonderful job.
Hmm. Okay, ji. So Dr. Neerav Godalia from Surat wants is saying that it's an excellent session. And could somebody please elaborate that which is the most common parasomnia and how to manage it?
Thank you.
Dr. Supraja.
Yeah, I think it is mostly sleepwalking and sleep talking, most commonly seen, and management, reassurance of parents, and identify, give a good environment, allow the child to sleep well, and reassure them, and behavioral therapy if warranted.
So can I also just add
Yeah,
one
sure,
point
please.
over here? See, all of us are actually seeing adult patients. So actually, enuresis will also be quite common. But obviously, primarily these patients will go to the pediatricians instead of coming to us. So I think enuresis and sleepwalking will be quite hand in hand, and the management, unfortunate or fortunately, will be taken over by the pediatricians.
Right.
They might not even come to pediatrician as well. So yeah.
Hmm. Dr. Atri, Dr. Umesh Kanoja from Gondia wants to know that how do you counsel the patients and their families regarding the safety concerns during episodes of parasomnia, especially when they're involved in some aggressive or wandering kind of a behavior?
First of all, we must convince the patient that you are actually doing these things, because often the patient will not even believe. The simplest thing of this is some family member must keep the sleep with the recording, that when that incident start, at least 10 to 15-second recording must be made, so that we can make the patient understand that you become a threat during sleep. For walking, you have to remove sharp objects that can cause injury. If someone becomes aggressive, access to weaponry must be removed. And weapon does not mean a sharp object or a gun. Any heavy object can become a weapon in such situation. So these two things should be clearly communicated. And if someone have this problem of eating food, then either that, if the gas cylinder is somewhere, if that cabinet can be locked at night, if the fridge can be locked at night, poisonous substances should not be present in the kitchen or dining area. These are few simple things we must reiterate to the patient and family members.
Right. So, guys, despite the fact that all of us have been on this platform for the last almost 2 hours now, yet people realize that we are just dummies, and the lady behind who's carrying the torch of teaching the entire crowd of pulmonology, Dr. Amita Nene, needs also to be appreciated. So, Dr. Sapnil Gharat from Aurangabad has said she's my favorite ma'am, and many thanks to her for organizing all this. So, actually, the credit goes to her completely and completely to her for organizing this wonderful uh, webinar on parasomnias, collecting all of us together and getting this done. It's not an easy job, guys. Believe me, she's doing a very, very wonderful job.
I
Fantastic job.
think I think all of us will echo what Dr. Swapnali Gharat is mentioning in the chat.
Yeah,
Totally.
absolutely.
Yeah, agree.
So I think we've already dealt with this, Dr. Neerav, about differentiating between non-REM terror and epilepsy. So I'll skip this
Yeah,
question.
yeah, it has been done.
This is a very long question from Dr. Jaykishan from Punjab, Patiala, that much importance is being given to a history of episode of parasomnia during early or late part of the sleep. Dr. Supraja, please be ready for this, huh? But
Yeah.
if person goes to bed early, then it can be a confounder for DD. In such a scenario, where the sleep study should be better to specify the cause of event from medical legal point of view.
So yeah,
Most
I have
in
an
the
interesting proposition for this such kind of questions, because as we have already discussed, you can't keep doing sleep studies every day. Rather than put a night vision camera or a surveillance camera to find out whether this is a possibility or this is happening, because what the question here is, they are trying to do the preventive part, identify it, and ensure that the crime is not getting committed. I don't know why they decided that the crime is going to happen, but if that is the case, if the person is going to be violent, then a camera will rather help. There are other again sleep wearables which are coming up, EEG wearables which are coming, which can also help. Very easy, portable ones are coming up in the market. So maybe one of those can actually help us to identify these parasomnias.
right, thank you. So, Dr. Uma, Dr. Pramod Jhawar from Madhya Pradesh Indore wants to know that can there be an overlap between non-REM and REM parasomnias also?
Ma'am, here we can't hear you.
Yeah, that is also known. Both there is a state dissociative parasomnia where everything merges into one, like REM into non-REM into wake. So it is very difficult where person can be hyperactive, they can be very restless, and this is also a known parasomnia, but it is very very rare. So they have manifestations of both REM and non-REM.
Right.
So will
So,
they have atonia or not?
They do have behavior like there won't be any atonia, they'll be enacting their dream also.
Dr.
But
Atri, you were
one and
talking about the medical
non-
legal aspects, but have you really encountered any such cases yourself also? This is a question from Dr. Jitin K from Cochin.
These cases rarely reach a doctor, because once this police and all come in the picture, then maybe psychologists, psychiatrists, forensic people are more into that. If you ask me, the most medical legal which I have encountered was when that lady was uttering names of some gentleman during sleep, and her in-laws had come to me very angry, and the other in-laws were very scared, and I had to show them lot of references from Google internet that these kind of thing happen, that maybe the lady was taking names of some gods and not some, let's say, male partner or whatever.
Really
Give the
interesting.
marriage
Atri, you've got a very interesting practice.
Yes, yes.
happening.
So, Dr. Vishal Goswami from Bhubaneswar wants to know, when do you recommend a polysomnography in suspected case of parasomnias? So, as we said, polysomnography may not have so much of a relevance, but it's more of a camera surveillance that is needed. Finally, we have somebody who's woken up from Delhi, Dr. Vibhor Chawla. I was just wondering that all the questions are coming from Punjab, Tamil Nadu, Kerala, Mumbai, Madhya Pradesh, but none from Delhi itself. I guess he's also come out of his parasomnia now and wants to know that can actigraphy or video monitoring at home aid the diagnosis of parasomnia? Obviously, yes.
Yes, it can.
Yes.
Yes. In fact, we saw some very good videos, when Uma madam was showing her presentation. I think all of those were at home only, so it really aids in the diagnosis.
Pramod Jhawar from Madhya Pradesh Indore is wanting to say that I also get some time solution of my personal problem in sleep. Is it normal? Probably you could contact Dr. Uma or Dr. Supraja or Dr. Kapil, Iyer, one of us, Nitin and Atri also. Keep me aside, but connect with one of them and they'll sort out a problem. So finally, there are appreciation for all of us from Jai Kishan, who's a pulmonologist in Patiala, Punjab. Excellent groundbreaking lecture by Dr. Uma. Panel discussion conducted by Dr. Nangia. Outstanding in-depth comments by Nitin, Kapil, Atri, and Supraja. Help to get an overview of parasomnias and insight. Interest for detailed study in Total. Very good. Excellent. Thank you. Supraja, you've been talking about bruxism. How is bruxism managed?
So
There's a question from Dr. Sunita Narayan from Thrissur.
sir, I think we should quickly finish off, otherwise questions are getting added up. So yeah, so bruxism basically, again, it is not a I mean, we do see that sometimes in our level 1 sleep studies. So nothing much to worry about, reassure, and if it's too difficult and unmanageable, then medications will actually help.
Right. So
Uh,
Ma'am, do you want to add? Yeah, Dr. Uma.
Just to add, for bruxism, sometimes patient can develop masseter
ICS.
enlargement, hypertrophy. They have severe erosion of their enamel. So you can have protective, like how they put
Devices, mat devices.
bases, covers, like rubber covers also is available. So that also helps. Most important is stress relief. Usually stress can precipitate bruxism.
right. So I guess, Dr. Supraja, you were just right that this was the last question that you got. There are no more questions. There are only words of appreciation now from Dr. Mushtaq Ahmed from Howrah, West Bengal, and Dr. Biswajit Sarkar from Cuttack, who say that this is the best module ever. And you all, sir and ma'am, have simplified the topic for me so much. And there was a lot of information that we've imparted this evening. Dr. Sri Shankar wants to know if there's any fellowship available for sleep. I guess you can get in touch with Dr. Amita Nene after this offline, and she'll be able to guide you on this. So there are sleep fellowships also, but best would be to contact ICS and get the right information from them. So with those words, I'd like to thank each and every one of you panelists this evening for not just taking out your time, but having such an interactive discussion and actually adding so much value and so much information this evening. I don't know about others, but believe me, I am going back much more learned. Our entire conversation was so much engaging and so much more informative than ever before. I feel one never thought parasomnias also could be so interesting and so in depth. The in depth knowledge that we've got today, probably we couldn't have gotten it in any other webinar ever. So I'd like to thank each one of you, Dr. Uma, Dr. Nitin, Dr. Supraja, Kapil, and Atri. And it's really been a pleasure moderating this panel discussion this evening for all of you. And once again, thanks to Dr. Samaria, President ICS, Dr. Rajadhar, Secretary ICS, Dr. Amita Nene, the main lady behind the academic programs for the pulmonologists in the country now. CIPLA team led by Hitain. Thank you so much, all of you. And we'll wind up here and sign off. Have a very nice night. And avoid parasomnias. Be safe.
And we also thank ICS for this opportunity and Dr.
Yeah, thank you, Dr. Amita, for the opportunity.
Yeah, thank you.
Dr. Ma'am, wonderful talk.